In terms of the reason why the genesis for this poster, we wanted to look at the role of estrogen receptor and in non-small cell lung cancer. There have been previous clinical trials that have looked at estrogen receptor that unfortunately haven't been successful, but we felt like trying to look, especially with the advent of targeted agents, both for tyrosine kinase inhibitors in non-small cell lung cancer, along with ESR1 inhibitors, we felt like it might be worthwhile to revisit this. We also published previous research showing, looking at estrogen receptor alpha positivity, showing that there's increased prevalence of estrogen receptor alpha positivity in females, along with those with EGFR mutant non-small cell lung cancer. So in this study, we kind of used a more updated database looking at expression, high expressors versus non-high expressors of estrogen receptor 1 and estrogen receptor 2 in non-small cell lung cancer. In our analysis, we were able to show that those with high ESR1 had increased prevalence of increased proportion of females, along with more enrichment of KRAS and EGFR mutations. We also showed that, conversely, in ESR2, we showed that it was a more equal distribution in gender distribution, and it was less enriched in EGFR and KRAS mutations. We then looked at MAPK signaling. We showed that there was ESR1 high and ESR2 high expressors had more interaction with the MAPK pathway. And then we also looked at survival data, and so we showed that both ESR1 high expressors and ESR2 high expressors had the highest median overall survival. We also showed that, on top of that, we showed that ESR1 high and ESR2 high, when combined together, the combination of the two had the highest expression in median overall survival. And then finally, we also did some exploratory analysis looking at patients who received Osimertinib and patients who received Sotorasib. Of note, in patients who received Osimertinib, we showed that patients who had high ESR1 and low ESR2 actually had the longest median overall survival. So these findings suggest that perhaps a more targeted approach towards both EGFR and KRAS mutations, along with estrogen receptor 1 and 2, may be a successful strategy for improving outcomes in patients who have these mutations.